Are you seeing my screen?
Yes, we are.
Okay, perfect. Let me just move this over. So yeah, thank you very much for the opportunity to be involved in this international webinar, which I think is an amazing collaborative across the world. And of course, I'm particularly delighted to be talking about one of my favorite topics, which is Ebstein anomaly in tricuspid valve in the fetus, and trying to focus a bit on strategies that we can improve outcomes in this very vulnerable population. So, just a brief overview about Ebstein anomaly. It was named after the doctor that discovered it, Wilhelm Epstein, in Germany back in the 19th century. And you can see here what is a pathologic specimen of a very typical type of Epstein anomaly, where you can see a very apically displaced septal leaflet and an atrialized right ventricle, with also very abnormal appearance of the myocardium. So, tricuspid valve dysplasia is a different entity pathologically, but I'll explain a little bit why we typically group them together. And tricuspid valve dysplasia is characterized by non-displaced septal leaflets, but a very dysplastic valve, often very nodular, irregular, tethered with limited mobility, and also can be characterized by abnormal myocardium, just like Ebstein anomaly. Now, the reason I'll show some fetal echo clips here, and these are the two sort of prototypes that you think about when you see an Epstein anomaly versus a tricuspid valve dysplasia. Here you can see that there is this apical displaced septal leaflet, and the orifice of the tricuspid valve is actually all the way down here, versus a tricuspid valve dysplasia where it's non-displaced but thickened and tethered. But in addition to the fact that there is a tremendous amount of morphologic heterogeneity and variation in these valves, ultimately, they both produce severe tricuspid regurgitation in the fetus. And so, whether that ends up being this very apically displaced jet or the very central jet, severe tricuspid regurgitation in the fetus ends up being very poorly tolerated, partly because the right ventricle is the dominant ventricle in the fetal circulation and really impacts overall central venous pressures as well as cardiac output. So I was fortunate enough when I was a senior fellow at Boston Children's Hospital working with Wayne Turetsky to be involved in this large multinational cohort of 250 fetuses with Ebstein anomaly or tricuspid valve dysplasia. The other reason why we group them together is because they're very rare diseases. And we looked at outcomes over a contemporary period at the time, although this was published now 10 years ago. And what you can see is that there were almost 20% of patients who experienced a fetal demise. And of those who were live born, about 1 out of 3 did not make it out of the hospital alive. And so, taken together, those two entities of Ebstein anomaly and tricuspid valve dysplasia had 45% perinatal mortality, which is really one of the highest mortality rates of all congenital heart disease that we care for. And we were able, given the large cohort, to look further at what were independent risk factors for perinatal mortality. And between our original paper and one of our ancillary studies, we found that the following were risk factors: an earlier gestational age at diagnosis, which makes sense, more severe disease tends to present earlier, a larger tricuspid valve annulus z-score, which is really just reflective of overall severity of tricuspid regurgitation, cardiac enlargement, pulmonary regurgitation, which I'm going to return to talking about when we think about the pathophysiology of this lesion and how we may modify it, a pericardial effusion, which can be a harbinger of evolving hydrops, again, likely related to overall elevated right atrial and central venous pressures in the fetus, and then an abnormal umbilical arterial Doppler. And I'm also going to return to talk about that particular finding in greater detail. So, in addition to severity of tricuspid valve regurgitation being tolerated because of those reasons that I mentioned, um, there is sort of a spectrum of the way that this can present pathophysiologically. And a lot of that has to do with what we think is going on at the level of the right ventricular outflow tract. And why pulmonary regurgitation and an abnormal umbilical arterial Doppler have come out to be such striking independent predictors of perinatal mortality. So let's review the pathophysiology. So if even in the face of significant tricuspid regurgitation, there is a well-functioning right ventricle and a normal pulmonary valve, you can have normal antegrade pulmonary blood flow with antegrade right to left normal intrauterine shunting across your patent ductus arteriosus. And this is a situation that we consider really the most stable form. So even if there's severe TR, as you can see in this clip here, you've got all antegrade flow across the right ventricular outflow tract, including in the ductus arteriosus. So this is a relatively reassuring situation, assuming, of course, that the fetus remains that way throughout gestation, because we also know that this can change. Now, about 20% of this population will have fixed anatomic right ventricular outflow tract obstruction. And in this setting, there will be left to right shunting at the level of the ductus arteriosus, which is normal in order to perfuse the fetal pulmonary vascular bed. And here's an example here where, by the way, this can be difficult to discern, but this was actually in a tretic membranous pulmonary valve. And you can see here coming in all of that duct with retrograde shunting. Now, the situation that we start to get worried about is when there's a normal appearing pulmonary valve, it appears to have leaflets that open, but due to the severity of the tricuspid regurgitation and often the failing right ventricle, which can be manifested as a low right ventricular systolic pressure and can be seen in both Ebstein anomaly and tricuspid valve dysplasia, which is very important. When that happens, then there starts to be reversed intrauterine shunting in the ductus arteriosus left to right because there isn't enough forward flow across that pulmonary valve. So these are cases where we start to get more concerned about both the severity of the TR, the health of the RV. And this is an example. This was a very tricky one for us, by the way, who we saw many times in gestation and we weren't sure whether it was functional or anatomic pulmonary atresia. But you can see that these leaflets do move. So they do move, but there's not really any antegrade flow. And you can see this retrograde ductal flow coming in to perfuse the main pulmonary and branch pulmonary artery segments. And this was a patient that was shown to have functional pulmonary atresia after the baby was born. Now, the final scenario, and the one that we worry about the most, is when in that setting of left to right ductal flow, pulmonary regurgitation evolves. And that's when we get into this very vicious cycle of cardiac shunting, which is also called circle of death, as named by Norman Silverman many years ago. And it's very true and a very poignant name for it, because essentially what happens is that you have this backflow into the right ventricle, into that weak right ventricle, severe TR, goes through across the foramen ovale, through that the left side of the heart, and then as it tries to go back down into the body, it just goes back through the duct and back into the right ventricle. So then you have a situation where you have very unhealthy loading of the ventricles, but also lack of systemic perfusion. You have systemic steal from the circulation back into the right ventricle. And this is what that looks like. So here you can see this is the aortic arch back here. This is the duct, and you can see all retrograde flow with a significant amount of pulmonary regurgitation. And these are certainly the cases that we worry about the most. So in addition to being a really important risk factor, the reason why pulmonary regurgitation and this finding of circular shunting is so important is because it's potentially modifiable. And so I'll take you through a case to illustrate just exactly how we can modify some of the aberrant physiology that can result from here. So this is an example of a patient at 31 and 6 weeks. And you can see here that there's a very dilated right atrium as well as right ventricle. And you can see the abnormality of the tricuspid valve here even before I add a color signal to it, in which case you can see that there's severe TR, not surprising. But then when we look a little bit deeper to try to understand what this fetus might be at risk for, you see that as you Doppler the right ventricular systolic pressure, it's a very low tricuspid regurgitant jet velocity, suggestive of a failing right ventricle. So that already is starting to make you a bit concerned. As you move on to look at the duct, you see that it's a nice big duct, but it's all reversed left to right shunting. You can see that it's the opposite direction of the aorta. And by Doppler interrogation, you can prove that continuously throughout systole and diastole, there is reversed flow in the duct. And then, of course, we get to the picture of the RVOT, and to understand what's happening at that level and to understand what the fetus's physiology is and what they're at risk for. And you can see here that this is also another case of severe pulmonary regurgitation, so evidence of significant circular shunting. But when we are looking at the fetus and trying to understand their pathophysiology, we have to be very diligent in looking at what's happening downstream outside the heart. How is it affecting various flows through the placental umbilical circulation, and what is the baby's cardiac output? So this is where the importance of really interrogating all of the extracardiac Dopplers and using them to understand what is going on with the fetus is so important. So we look in the brain to see what kind of perfusion is going on in the brain. We look at the ductus venosus, and that gives us a sense of right atrial and central venous pressures, similar in the umbilical vein. And then we look at the umbilical artery, and that's really our surrogate of what's happening with systemic perfusion and looking for evidence of systemic steal that may result in the context of significant PR. So similar to how we found that PR was so worrisome in terms of a risk factor for perinatal mortality, when we looked at many of these variables, including many of our extracardiac Doppler signals, we see that the absence or reversed pattern of diastolic flow in the umbilical artery also connoted an almost tenfold odds of either fetal demise or neonatal mortality. So that corroborates the findings and underscores the importance of looking at all of these downstream indices. So when we return to our patient, just to illustrate what it looks like, you can see that there is a wave reversal in the ductus venosus. So you've got high right atrial pressures, and this is the context of a normal fetal cardiac rhythm. We'll hear more about abnormal rhythms in the next talk. When you look at the umbilical artery, you see that there's absent and actually reversed end diastolic flow, again, consistent with systemic steal. A similar finding of decreased end diastolic flow in the middle cerebral artery, and then a very concerning pattern here of umbilical vein notching, which is often considered a really pre-terminal finding in the fetus. And just to comment on how else we can sort of prove that this is what's happening in the fetus, I have the luxury here of working with our fetal cardiac MRI team. And this is the patient, and you can see that there's very severe tricuspid regurgitation here. But when we look at flow patterns, we can see quantitatively that in addition to what we're understanding from the umbilical arterial and middle cerebral artery Dopplers, there's markedly decreased perfusion to both the brain and the fetus's body and placenta in the context of circular shunting. So what we have here on the left are relative distributions of cardiac output in a bunch of Ebstein anomaly patients without circular shunting. And here, what I'm highlighting in green would be the normal proportions of cardiac output to the descending aorta and to the brain, which we look at through SVC return. Now, when you look on the right hand and you look at what happens in a fetus with circular shunting, you can see that you essentially have reduced the cardiac output by essentially 50% to both the brain and the body. So all of this is sort of consistent findings and speaks really to the gravity of what this finding looks like, specifically when you start to see that your umbilical and middle cerebral arterial Dopplers are abnormal. So the idea was posed that, well, we typically recommend that pregnant women do not take NSAIDs because we know that that can cause constriction of the ductus arteriosus. But what about in this particular situation where constriction could actually mitigate that circle of death and perhaps stabilize the baby and improve their overall brain body perfusion. And so the idea, the conceptual paradigm behind initiating NSAIDs is that you can stabilize the fetal circulation and permit that baby to survive longer in pregnancy, be delivered closer to term. And we know, of course, that our babies with severe congenital heart disease will always do better if they are larger and more mature. And that, therefore, is a pathway to improved survival and potentially neurodevelopment, which I'll address as well. So in this mother, we discussed NSAIDs with her, and she agreed to give it a go. And 3 days later, this is the duct here. You can see that it's significantly constricted. And you can prove that by your Doppler signal as well. And most importantly, what you can see, you often do see, by the way, improvement in pulmonary regurgitation, reduction in high drops, all of those things. But perhaps what's most important is that, and most striking, is the resolution or improvement of the extracardiac Dopplers soon after initiation. So here you can see that your ductus venosus has actually normalized. The umbilical artery has restoration of antegrade diastolic flow, as does the middle cerebral artery. Really important when we're thinking about long-term neurodevelopment in these children. And then you have normalization of the umbilical venous flow as well. So quite a satisfying turn of events. And again, together with my mentor, Dr. Turetsky, we undertook a study a couple of years ago where we were in contact with different centers, 10 centers across the world that had offered NSAIDs for this indication to 21 mothers at a median gestational age of 30 weeks. And what we saw is that if you looked at women who consented and where the fetal duct was able to be constricted, almost all of them made it to live birth. Whereas those who either declined NSAID therapy or who were unable to achieve ductal constriction, less than half of them made it to live birth. And that was actually a statistically significant difference. Beyond just survival to live birth, if you look at the gestational age at live birth, you see that we were able to get these fetuses born at 36 weeks versus 33 weeks, which is really a world of difference when you're trying to manage them in the neonatal period. And just to corroborate what happens physiologically, we've also looked at fetal cardiac MRI in terms of what happens with the various flow metrics after NSAID initiation and successful ductal constriction. And what you can see is here is prior to indomethacin, here is after indomethacin. You see huge jumps in flow to the brain and to the baby's body and placenta as you have mitigated the flow through the duct and therefore through the circular shunt. So as I've alluded to before, when you think about the implications of this, it also can help with neurodevelopment. Looking at fetal brain weights in various fetuses, a control group, Ebstein's without circular shunt, and Ebstein's with circular shunting, not treated with NSAIDs, you see that this population has the lowest fetal brain weight, which we are beginning to appreciate and understand is associated with later neurodevelopmental delays. So the idea behind NSAIDs is trying to make this group more similar to this group here without a circular shunt that you see in blue. Now, of course, there are other things to consider as the pregnancy goes on and whether or not there's circular shunting. When we looked at this cohort as a whole, we saw that another really significant risk factor mortality when we looked at the neonatal cohort was gestational age. And not surprisingly, we were able to find that those that were born less than 37 weeks had a fourfold increased risk of perinatal mortality as opposed to those born after 37 weeks. So may not be the ideal 38 to 39 week fetus with congenital heart disease that's born to go on for their neonatal cardiac surgery, but given the instability for this particular population, we really do still try and get them as far along as possible and ideally to 37 weeks. Now, in this follow-up study that we published in JAHA, there are a couple of other things that I want to report on that are very important, which is that 7% died within the first 24 hours of life. So that's a tremendous amount of early mortality that I want to discuss a little bit further. And then we have an additional 20%, 25% that died prior to hospital discharge. And in thinking about those early deaths, many people working at large congenital heart centers don't really hear or start thinking about these children potentially at this stage when you see the wall-to-wall heart on chest x-ray, the torrential tricuspid regurgitation at neonatal echocardiogram. But I really want to make the point that management for these patients has to start in utero and has to continue until the time of delivery. They actually not only don't tolerate delivery well, they oftentimes will get significantly worse. So a really critical period of time. And so, of course, as a fetal cardiologist, and I happen to throw this out as a lead to Dr. Strasburger's lecture, but certainly these patients are at risk for arrhythmias. And this was a patient that had actually both reentrant SVT and atrial flutter. So we have to think about antiarrhythmia therapy. As fetal cardiologists, we have to think about NSAID therapy for those cases with severe circular shunting. And in conjunction with our high-risk OBs, we need to think about what else we can do to get this baby as close as possible to term with very close surveillance. And then as late gestation approaches, delivery planning with a comprehensive multidisciplinary team is essential, and an OR backup should really be discussed for those cases with significant circular shunting in order to mechanically interrupt it. And I'll discuss a little bit more about that in a moment. When we looked at what were the risk factors for neonatal mortality, of course, it was all the fetal risk factors plus lower weight and lower right ventricular pressure as measured by TR jet velocity. And we know that this is a risk factor in general for circular shunting as well. So now that you have a patient like this, what exactly are you going to choose to do with your team? And I just want to underscore how important it is to really understand what that right ventricle is capable of. And that is both echocardiographically as well as clinically, of course, what the patient is doing at the bedside. So here you have a patient with a very borderline right ventricular systolic pressure. And these patients can be really troubling to decide on the correct approach. But it is important to remember that TR jet velocity is really correlated with what the overall neonatal outcome is. So those with the lowest TR jet velocity were more likely to die, and those with the best TR jet velocity were likely to make it out of the hospital alive with a biventricular circulation. And those with TR jet velocities in the middle oftentimes had a palliated outcome in between. So just to look at sort of the spectrum of outcomes. And when we look at how these were managed, there was really a broad spectrum of management across institutions. And what you can see when you look here, purple represents those that died, blue represents those that survived. And what you can see is that the only surgical approach that was able to get all of these children out of the neonatal period alive was the right ventricular exclusion procedure, or Starnes procedure, as is often called. And for those that aren't familiar with what this is, here's a brief picture, but it essentially involves putting a fenestrated patch over the tricuspid valve and excluding that right ventricle, which is often very deconditioned, and excluding the torrential tricuspid regurgitation from the circulation. And so essentially, you're making these children single ventricle, but only temporarily, and I'll get to that in a moment. Oftentimes what's done is there's either the ligation of the main pulmonary artery or patch placement. There's a modified BTT shunt in order to provide pulmonary blood flow and atrial septectomy. And then the right atrium and right ventricle are reduced and plicated as well in order to allow for greater lung expansion and stability after the procedure. And so this is what it looks like. Here is your fenestrated patch over your tricuspid valve, and you can see that the right ventricle has become quite decompressed, and that will also facilitate your left ventricular cardiac output in dynamics, which is very important in this fragile period. And here you can see that fenestrated patch. And in our institutional approach, we look very carefully. We start Of course, what's really important is that when we start thinking about these children, not in the neonatal period, but in the fetal period, and very important in our algorithm is not just whether there's anatomic or functional outflow tract obstruction, but also right ventricular pressures, and the most severe children on either pathway will ultimately end up with a right ventricular exclusion procedure or the modified Starnes. And this was an algorithm that we put into place several years ago based on the data that I've shown as well as others' data. And I was really thrilled to see that in the recent iteration of the AETS expert consensus guidelines regarding the management of neonates and infants with Ebstein anomaly, they continued this message, which is to say that those with Ebstein's or tricuspid valve dysplasia, I'll add, with circular shunting, hemodynamic instability, and a low right ventricular systolic pressure cannot be medically managed. Really, they can't. And so the best thing to do is to interrupt the circular shunt. And that can be with an isolated main pulmonary artery ligation. Um, Initially, if there's not the stability and resources to do a full Starnes, or straight to a Starnes procedure. Now, what's really exciting about what's happening in this field is that now that we've understood that a Starnes is the safest way to get these children out of this very tenuous neonatal period, we're becoming to understand more and more that it doesn't mean that the patient is destined for single ventricle management. So after the Starnes procedure has been done, tricuspid valve repair using the De Silva cone technique can restore a 1.5 or biventricular physiology. And there's growing experience with this, mostly by Dr. De Silva's group out of Pittsburgh, but we've also undertaken some cases, and I know other centers are starting to as well. This was one of their most recent updates of 11 patients that they have operated on since 2019, where they've been able to, for these 11 patients that had the Starnes, they've been able to convert 7 of them to a 1.5 ventricle circulation and 4 with a biventricular circulation, and no early mortality. And they've gone so far as to actually propose an algorithm for how you might approach Starnes takedown. And similar to a neonatal algorithm, a lot of it is dependent on whether or not there is functional versus anatomic pulmonary atresia. And of course, in either of these scenarios, a Glenn might be needed in order to help with that right ventricular loading. So I want to summarize by saying that I think that we've learned a lot in the past 5 to 10 years about how to manage the most severe fetuses and neonates with Ebstein anomaly or tricuspid valve dysplasia and circular shunting. And of course, it's a stepwise approach. None of them are undertaken in isolation, but really for the sickest fetuses, with circular shunting, I would encourage the consideration of NSAIDs therapy to stabilize them in utero, coming together with the team in late gestation to develop a very comprehensive multidisciplinary delivery plan. And then what may very well be needed, and what we've certainly taken the approach on, is to be very aggressive and urgently surgically interrupt the circular shunt in the early period in order to provide a more stable neonate that can make it through a very rocky neonatal course. But again, want to remark that that does not commit the patient to the single ventricle pathway. And the last plug that I just want to make is that as much as I love studying this disease, I even love more studying it with all of you. It's a very rare disease where we have a lot to learn. And so several years ago, we started the FEAT registry, which is the Fetal Ebstein Anomaly and Tricuspid Valve Dysplasia Registry, which started as a prospective, but now is also a retrospective ascertainment of cases that we're following from the fetal period for as long as possible to understand their courses, including their neurodevelopment. And I'm really proud to say that we've got over 40 sites enrolled on over 4 continents, but we're always looking and keen to have more collaborators. So if anyone is interested in joining this force to understand and improve this disease, please feel free to either reach out to me directly or to the FEAT registry at the email that you see here. So thank you very much for your attention, and I'm happy to take questions.
Thank you so much. Do you hear me? I just want to make sure that, okay, it was a beautiful talk as expected, Lindsay. We have lots of questions, things to learn from you. Now, you said it's a rare and a bad disease. So, um, from what you've seen, if you want to choose a spectrum, the worst Epstein and the best Epstein, can you tell us?
Yeah, that's a great question because it definitely is a very wide spectrum, both in terms of the underlying anatomy and morphology of the tricuspid valve, as well as how they present. The most mild cases are the ones where there is sometimes you see a really markedly displaced tricuspid valve, but there's actually almost no tricuspid regurgitation. Um, and those are patients that you would expect to continue to have antegrade flow across the right ventricular outflow tract and duct and to be markedly stable. And we certainly see many of those. I showed an example of a patient that actually had severe TR, but still there was all antegrade flow. And in that setting, I talk about an elective or semi-elective cone repair at some point in the child's life, but really we don't plan for any significant neonatal management of those children. We watch them while the duct closes, make sure their saturations remain robust, but we tolerate saturations certainly in the 80s for those patients, and then they gradually improve over time. So that's kind of patients that are more along the mild spectrum. And then the severe ones are really those ones with circular shunting. So they've got, there's no antegrade flow, there's pulmonary regurgitation. So they're caught up in that dizzying cascade. They've got evidence of low cerebral and systemic perfusion, and also, high filling pressures, high drops, and so we certainly see hydropic patients as well in this setting. And the hydrops itself can also be mitigated by NSAIDs. Sometimes you don't see complete recovery, but sometimes you do. And that can be obviously very satisfying when it completely reverses itself. And then the last thing that I'll mention again, just as a segue maybe into the next talk, is that we do see fetal arrhythmias in this population, perhaps not as commonly as was once thought. In our series, we saw them in less than 5% of the cohort, but when they do develop arrhythmias, on top of all of that pathophysiology, they can become quite unstable very quickly. And so those are, of course, ones that you're going to want to aim to control as quickly as possible.
Well, I wanted a more specific answer because when we're counseling, like as you said before, you go for the Z score. So can we do that together? Z-score, because postnatally, we look at the baby, we see the degree of displacement, the Z-score. Now here, what you've said, the cardiac function is very, very important, right?
Mhm.
So if you think that what Z-scores and the presence and absence of pulmonary regurgitation, so what are the nightmares? We know that circular shunt is a nightmare. And so before that, anything in between the borderline cases and the is the degree of displacement or the cardiac function or the pulmonary anatomy or all of them will be a part of counseling?
Yeah, that's a great question. So while I measure the tricuspid valve Z scores, and we certainly use them for research purposes, I think they're surrogates of severe disease. And the there are different sort of schools of thought in terms of how you counsel and how much quantitation you use versus pathophysiologic driven counseling. And I'm in that latter camp where I don't tend to really get mired down in the quantitative numbers as a way that I counsel patients. I'm much more, I'm thinking about what is the pathophysiology. So not to hang my hat at any one number, like the tricuspid valve Z score or the CTA ratio. I mean, we certainly report all of them, but I think it's part of a larger picture. And I think what sometimes can be misunderstood about this disease is there's an over reliance, perhaps, on some of these quantitative metrics or some of the scores that have been put in place without really stepping back and thinking through what might happen for this baby. And so for me, what's happening between the right ventricular function and the TR jet velocity and what's happening at the right ventricular outflow tract probably guide much of my personal intuition of how I think the rest of the pregnancy and the neonatal course is going to go.
Great. So in this case, there are lots of questions. Before we go everybody's asking about PDA closure. Would you do like strain and strain rate and or the cardiovascular profile score to follow your case? Because we don't know. You see them. I know, I mean, no one would like to get an Epstein antenatally, whatever spectrum you say, but
Sure.
unfortunately, we do see them. So in this, if we do, well, you do cardiac MRI and you do flow and you cardiac output, people who don't have this luxury can strain and strain rate help with cardiac function and follow up and all that?
Well, so I think that's a really excellent point that you brought up about the cardiovascular profile score. And actually, we have
He's easy.
uh,
Hunter is my mentor, so I have to talk about that.
yes. Okay. Yes. No. So actually, we have a paper coming out that, well, it's just being submitted now, where we looked actually with Dr. Huda and Grace Fair, and we looked at the cardiovascular profile score in this cohort of Ebstein anomaly and tricuspid valve dysplasia. And I fully agree with your point that not everyone has cardiac MRI, for example. And the cardiovascular profile score, a lot of people may already be doing it for various other pathologies. So to translate it for Ebstein's may be another way that people can just sort of follow severity. And so you'll see sort of that paper coming out where we went back and assessed. And so I certainly think one of the nice things about the cardiovascular profile score, and the reason why I actually really like it, is because it automatically incorporates all of the extra cardiac Dopplers, which are so important to understanding what's going on. And so those are kind of already embedded in. And so in that case, just as another sort of reminder of how important those are to how we're thinking about these patients. That's where I like the cardiovascular profile score.
You
And
can
I do think it can be useful.
It can be useful, but you cannot depend on it solely in your decision because there are also
For
drawbacks for
sure.
the score. But yeah, I think it's great. Everyone's asking about the closure of the PDA. So to go back, closure of PDA is indicated only in circular shunt patients. Is this correct?
Yes.
And the next question, what gestation age you can start? And I would say, what cardiovascular profile score would you start it in, like 7 or 6 or whatever, or before that? So when do people would like to start the non-steroidal and the dosage, please?
Yeah, so it can be started at any gestational age, really, but we do see that the duct becomes more responsive to NSAIDs as gestation progresses, which is not dissimilar from what we see with our premature population, where we see much more response later. So, and they don't all respond, by the way. Probably about 70 to 80% will respond, but there are non-responders as well. And so for that reason, we sort of, you can titrate the dose. What we use is we use indomethacin, and we often start with 100 milligrams twice daily. But, it really, you have to keep a very close eye on what's happening with the fetus and be ready to both increase or decrease that dose based on what you're seeing. Like Dr. Turetsky tends to say, my mentor says it's almost like doing fetal critical care, right? You can imagine, for some of these unstable babies where you turn on and off the prostaglandin to see how they're doing, that's kind of like what you're doing in the fetus. So you need very close monitoring, lots of repeated studies to really look at how it's playing out with the pathophysiology of the baby. It's not sort of like you write a prescription and you send them home and you see them back in a week. It's not one of those types of endeavors. I'm always happy to help if a center is trying it for the first time. I'm happy to be a resource. I do that all the time because I think it's important that we understand why we're doing it, what to follow, and all of those types of things as it's still in its early experience. And then, of course, I would love to have such cases in the registry as well so that we can all learn together about really the impact of this and how to best manage it in these high risk babies.
I think registry is very important. It's important in all types of research and collaborative learning. So I would also encourage our colleagues, our audience, also to email Dr. Freud and see how to gain from her experience and also share the numbers that they have. But Lindsay, like now I'm pregnant with a baby with a circular shunt and Epstein anomaly, and I would say the score is 6 or 7. So I come to you first. Are you going to admit me? Is it an admission? And then what is the protocol and what will be the labs that you ask for simply for people to know before we go to the registry and stuff like that? So they want, well, how often you're going to give it? I know postnatal, I mean, it can cause necrotizing enterocolitis and bleeding up for
Mhm.
babies and stuff like that. But I don't know antenatally, how do you monitor that?
Right. Well, so one thing is that if you join the registry, we actually do have a guideline. Now, it's a guideline, it's not a protocol. This isn't a trial, so you don't have to follow it strictly. And of course, clinicians can always decide exactly how to navigate. But we have sort of spelled it out how we would recommend monitoring. For the moms, of course, you want to make sure that she has normal renal function at baseline and that she doesn't have any contraindication to NSAID. So that would include all the usual things with bleeding diatheses or, ulcerative gastro, um, gastrointestinal findings and things like that. The the in the fetus, the major issue that we do see sometimes is that it affects the fetal renal function acutely, and so you can get some oligohydramnios. We see it in varying degrees, and it typically, as soon as you stop it, if the oligo is concerning, which it often isn't, so if you're doing NSTs, if you have oligo, but you otherwise have all reassuring indices of fetal well-being, the oligo itself is not necessarily a problem. That's what my MFM colleagues have taught me over the years. Anhydramnios might be something a little different, but typically as soon as you stop the NSAIDs, the fluid returns. So it's very transient. And again, I think that when you're thinking about risk benefits, and there certainly are risks benefits to everything we do, remember that we're using NSAIDs in the most severe fetuses that we think are at very high risk for perinatal mortality, whether that's fetal demise or neonatal death. So we're really trying to do something meaningful to a very, very already very severe group of patients. And so when we see renal dysfunction, even after birth, or you see neck after birth, it's hard to know what comes first, the chicken or the egg, because obviously these very sick patients are already at very high risk for renal dysfunction and neck. So again, that's the beauty of the registry, where we're having patients enrolled that are not necessarily receiving NSAIDs. And it may not be your center's preference or an individual physician's preference or something they want to recommend for their patient. But by having in the registry patients not receiving NSAIDs and receiving NSAIDs, we can control and start to understand, is there really an increased risk of postnatal renal dysfunction or neck beyond what might be expected in the setting of a severe Ebstein's in the first place?
So this is um, just what about the fetal lungs endomedicine?
Yeah, thank you. I saw that question
Risk
in
for
the
the fetal
chat.
lungs?
So the lungs actually really do not end up being much of a problem either scenario. We see that they have these wall-to-wall hearts. And actually, this was something that we talked about a lot. We just hosted actually an Ebstein's Anomaly at Sick Kids, and from what I understand, those lectures will also end up being available on Congenital Heart Academy after a certain period of time. We talked a lot about the lungs, and they can be a problem, but they're not as much of a problem as I think that we think they might be, just looking at, for example, what the chest X-ray looks like with that wall-to-wall heart. And the lungs actually end up often being able to expand pretty well. And we haven't seen any issues with sort of lung development. When we give the NSAIDs, it's very, very, very rare that we get complete ductal closure. It's more of a constriction. And so there is still blood flow that's going to the lungs. It's very rare to have a complete closure, although it has been reported.
So I mean, it's a sort of balance, really. It's a situation, right? You're
Mhm.
trying to help the baby, and really, the message here is that prenatal diagnosis might improve the neonatal outcome, because we know that if, I mean, you just watch them in utero and you counsel that it has to be delivered in a tertiary care center where there is a lot of facilities and a ventilation or whatever. So just the message here is that we're dealing with a bad disease, and the going for the for non-steroid is just like trying to help, and it proved what Lindsay showed, that the outcome is quite good, actually. And the outcome means the neonatal mortality and morbidity. And I think you just bridged them to a sort of 37 weeks. Did we get 37 weeks in your studies, or were
Yeah,
they
I mean
born
it's a
prematurely?
spectrum, and that was a retrospective study, but ideally, it's these patients obviously need to be followed very closely. The other thing about NSAIDs to remember is that the offering NSAIDs is one of the only things we can really do with pretty well tolerated risk profile for the mom and the baby, right? And so obviously we can treat an arrhythmia, but other than that, if you're not using NSAIDs and you're just kind of watching it evolve, you can feel kind of helpless, right? You're seeing a baby get sicker and sicker and sicker, and you're not able to offer anything, which is always a challenging situation for, not to mention ourselves, the mothers, right? They've counseled and they're watching it progress. I mean, it's something that we can offer, and I think it's not going to work 100% of the time, but it's something. There aren't many things that we do that work 100% of the time, and so I think that's where the opportunity of NSAIDs exists, and we should explore it further. But then, of course, it's part of a continuum of care. So, like you said, Rima, we want to get these patients ideally as close as possible to 37 weeks. Can't always happen for the very sick, unstable fetuses. And then it's really also part of a continuation of strategy with your surgical colleagues, your intensive care unit colleagues, to recognize that in the face of significant circular shunting, you cannot medically manage those children. They need to have the circular shunt interrupted. And that can be done in a variety of ways, depending on what the right ventricle looks like. Usually, the right ventricles are pretty sick in those instances. So, a ductal ligation is probably not going to work, but it could be a main pulmonary artery ligation or banding or just going to a Starnes. And that has been our approach in recent years, is to do a Starnes. And then, as I've mentioned, we are also we are doing Starnes takedowns here now as well when they get older, and that's been a really exciting revolution in care for these patients as well.
Regarding the non-SIDS postnatal, you just presented and you said, okay, we wait till the duct closes. I'm just thinking, okay, well, why don't you start if indicated at all? Can you medically close the duct in those babies?
Oh, and the very sick ones where you think that
Yeah,
the duct can be closed.
yeah.
I guess if the strategy is such that there is a good right ventricular systolic pressure and there's good antegrade flow across the pulmonary valve, and you are dealing with a duct that is causing you problems, but you otherwise think, then I guess it could be attempted. If the group discussion is such that the thought is that the baby would do well taking the duct out of the equation, then that could be an option. If it's a little unclear though, one strategy is to bring them to the operating room and try to ligate the duct, but knowing that if that's not going to work, the baby's not destined to be biventricular early, then you can just pivot to doing the starts. And I think that's just a really important um, strategy to keep in mind, because we don't always know what the right ventricle is capable of.
Lindsay, any genetics done on those
Great
babies?
question. Also, so some of these patients, of course, like with any other major fetal anomaly, we always recommend at least baseline genetic testing. So Ebstein's and tricuspid valve dysplasia, with or without anatomic pulmonary atresia, can certainly be seen in Down syndrome. It's probably the most common genetic abnormality that we see, but there are others. And so, at least at our institution, we for any child that's undergoing a major heart operation, either pre or postnatally, we recommend starting with a karyotype and microarray, and then we may go on to panel testing or sequencing exome or even genome if they qualify based on the rest of the findings. But trisomy 21 is the one of everything that we've seen that tends to be the most common, and it can occur in like up to 10% of these cohorts. So
Thank you. My last question to you, I know we've asked it quite a lot. What about heart failure? Because I mean, if we have hydrops, if we have circular shunt, if we have poor cardiac function, do you think with the non-SIDS or without, can we start anything to treat the heart failure like lanoxin? Because the HUTA thinks you can, and this will improve the score by 1 or 2. I'm not sure what you think.
do you mean digoxin? Sorry, is that what you?
Yes, yes,
Yeah.
lanoxin toxin, yeah.
Yeah, it's a really interesting question, and I don't think we know the answer. I think that, and it's actually one of the questions in the registry that we're asking people to put data about, is because I have heard of people using digoxin, and I've heard varying results. At our center, and personally, I don't tend to. Actually, I don't think I've ever for an Ebstein's patient. For some of the cardiomyopathies, when you feel like you want to try to do something, I have tried. But I would say that, sometimes you see it helps a little bit, but it's not convincing. But I think it's a great question and something that needs to be explored more.
I tried it on one of my patients recently, and I did see very slow improvement. But then I was happy because there's nothing that could be done. But the MFM told the mother, "Stop it; it's useless." So she stopped it.
Well, and it is important. What I would say, though, in that setting too, is that when you end up using higher doses of digoxin to cross into the fetal placental circulation, you do want to make sure that you're just checking mom's EKGs because it's pretty easy to end up with first degree block or other findings in mother's EKG. So that's just important to monitor. But barring that, yeah, I mean, it's probably not harmful.
Thank you so much, Lindsay. I think we're encouraging colleagues to share their information and patients with the registry. And now I'm very honored to present our second icon in the talk, Dr. Janet Strasburger, and she is like the most known figure worldwide with the magnetography, which is simply a way to understand the details of fetal arrhythmias. As we all know, that we don't have a fetal ECG until now. So how can we understand the intervals, the QT, the PR, and so on? So Janet is going to tell us more and more of a very important topic on the Epstein. And as Lindsay said, that Epstein, as we all know, they are prone to have arrhythmias. I don't know why, but I think maybe some sort of inherent factor in the myocardium, and maybe Janet can answer that. Janet, please share your
Well,
screen, and thank you for
very
coming.
much. Thank you so much for allowing me to talk today. And I really enjoyed Lindsay's talk and hope to participate in her registry going forward. I wanted to just talk a little bit about arrhythmias in this situation. And what I will talk about today is probably not what you'll think that I would talk about. More often you hear about the arrhythmias that we see with ultrasound. But what I'm going to be talking predominantly today is about the silent conduction abnormalities and arrhythmias arrhythmias that only can be seen with FMCG or FECG. Unfortunately, FECG doesn't have the quality to be able to see that. So this is just a picture from last year when we crossed 1,000 cases. We've seen about 200 cases of congenital heart disease. About half of those also had associated arrhythmias, and we've studied about 200 normal subjects, but the vast majority of the patients we see in Wisconsin come from outside of the region and have to travel. So our effort is really to try to improve the ability for patients to be able to have the procedure. We're collaborating with a number of people at different institutions. You can see in the lower right, Dr. DeWert from Michigan and her daughter. In the upper right, you have Annette Walker Guzman, who's in Munich, and she actually has a system that is able to do really high quality FMCG. So for those of you practicing in Europe or the Middle East, you may want to think about Dr. Guzman's work in Munich. Dr. Srinivasan in Madison. What you may not know is that our programs in Madison and Milwaukee recently merged, and we have a joint program now. Dr. Cuneo is one of our longtime collaborators, and we work with a lot of the fetal care centers, and we thank you all for sending us patients. This past week, we've managed cases from as far away as Edmonton, Alberta, all the way to Hollywood, Florida. So we definitely see a lot of different types of arrhythmias, and today I'll be presenting our experience with that. Now, our goal is really to develop technologies that can be in every fetal care center. So in the lower right is a device that we are hoping will be shipped soon for us to test in Madison. It uses optical sensors, which are inexpensive. The problem that we've had with the squid, which is on the lower left, has been the cost of it. It requires helium, which is in a shortage right now. And so, I think that the OPMs will likely be the answer in the near term for getting systems out to other sites. We also just started a collaboration with a group in Boston looking at solid state quantum sensors, and that's really in its earliest phase. But the group in Madison that I've worked with for 24 years, these medical physicists have invented such things as tomotherapy and digital subtraction angiography. So if anyone can do it, it's this group. So in terms of what are some of the advantages of FMCG, we can determine a lot of arrhythmias just by echo alone. And so here's what I consider the advantages. The first is that we have beat-to-beat continuous recordings, and that allows us to pick up little brief things that may not show up. It allows us to look at, as you see in the upper, I don't know if you can see my arrow, but in the upper left, you can see fetal movement here in red, the red circles, and you can see changes in heart rate over time, which is a heart rate trend graph there. You can see in the bottom left the rhythm strips that we get. We usually tend to leave the mom's EKG on the lower rhythm strip just so we can differentiate what's baby and what's mom. We do the signal averaging in order to make our measurements for the cardiac time intervals. And finally, we do full disclosure so that we can present this eventually to the FDA and have them believe that that this is really what we're seeing. So this is just all the different arrhythmias that we can determine by echo. And this is a lot, and this is really good. But what I want to talk about today isn't this. It's this, and that is the silent conduction disorders and diseases and defects in congenital heart disease and in cardiomyopathy and in other diseases where it may not show up on echo. So things that we are looking for are things like large, wide, or fragmented P waves that may go along with a higher risk of atrial tachyarrhythmias, the presence of enlarged P and QRS complexes to suggest the degree of hypertrophy, the presence of complete Bonnebranch block, which you'll see is important in Ebstein's malformation, unstable QRS morphology, which can be seen with different changes in rhythms as well as with heart block, WPW, which usually you'll see a short PR, mechanical PR interval by echo, but not always, especially in congenital heart disease where the P wave may be wide. And of course, prolongation of the QTC, which can also be associated with T wave alternans and QRS alternans in some of the inherited arrhythmia syndromes. We're looking for ST depression and elevation, and basically we measure this as a splaying from the baseline of the end of the QRS. And we sort of have arbitrarily said that if it's more than 10% of the total QRS amplitude, it's probably significant. And we look for heart rate variability. And finally, we're looking for those types of arrhythmias that are very transient, ones that may be so short that you might not catch them as you do a fetal echo. And this could include things like pathologic decelerations, paroxysmal VT, AET, or flutter with, especially flutter with one-to-one conduction. I'll show you an example of that. Low atrial rhythms or non-sinus rhythms. And finally, the presence of things to suggest conduction abnormalities like first or second degree AV block or even complete heart block that's transient. So why would it be important to detect silent conduction disease? Well, there's things that you can do about it. One is you can mitigate risk factors for stillbirth by treating arrhythmias that you may find. In an article that we published in 2022, we showed that about 40 to 50% of patients will have arrhythmias that weren't detected by echo, some of which require treatment and some don't. You can also adjust nutrition in the mother to get rid of deficiency states that are prorhythmic. And you can halt QT prolonging drugs that she might be taking for other reasons. You can increase your surveillance of the fetus. And this is especially important with Ebstein's malformation. And I'll show you some examples of how Ebstein's progresses between the second and the third trimester. And you can look at delivery timing. We're sort of taught that 39 weeks is ideal for the baby with congenital heart disease, but is that really true for all of the Ebstein's patients? You can look at potential influences on surgical management, like, do they require some kind of a EP study for WPW or assessment of LV function or temporary wires if there's some transient heart block. And finally, it can be important in parental counseling in conjunction with the echo findings. So across all ages and across all populations, arrhythmias and conduction abnormalities are important in prognosis long term. And so when we look at a disease that has such a high mortality, like Ebstein's malformation, where the mortality is anywhere from 17 to 45%, it is important that we not ignore things that even in the adult may have important implications in long-term survival. So this is just a Finnish study where they looked at QRS duration, and it was fairly young men, and they showed that for every 10 millisecond increase in QRS duration, that there was a 27% higher risk of sudden cardiac death, and that this risk was equal to that of cigarette smoking. And also in the highest quintile of those with QRS durations above 110, they had a 2.5-fold higher risk of sudden death than those that didn't. And of course, we all know that Ebstein's malformation patients do have a wide QRS. And so, we may need to think about that, especially long term as we look at adults with Ebstein's malformation as well. And the mechanism is that it usually underscores the underlying disease state of LVH or LV dysfunction. An increase in the QRS is a substrate for monomorphic VT. It can be more complex VT and more likely to degenerate into VF, and it's less likely to be defibrillated. The increase in the QRS is also arrhythmogenic, especially in combination with arrhythmias or drug use, medication use. And of course, in tetralogy of flow, we all know that one of the pillars of tetralogy long-term survival, one of the risk factors is QRS duration above 180 milliseconds. So it's not just depolarization abnormalities in the adult, child, and fetus that impact survival. It's also repolarization abnormalities. And in the interest of time, I probably won't go through each of these, but Dr. Schwartz showed that in babies that had a QTC longer than 480, that there was a 43% of those had long QT mutations, and about 10% of SIDS are related to this as well. And in the fetus, we've shown in our study by strand that if the QTc is above 590 milliseconds, that there's a significant risk for the LQT-related arrhythmias that I list here: torsade, T-wave alternans, 2-to-1 block, and late-coupled PVCs, and finally stillbirth. And then an interesting recent article by Merck et al. Showed that in 85% of the 55 stillborn infants that they studied, 85% of them had at least one VUS for one of the diseases of cardiac IAS, cardiomyopathy, or congenital heart disease genes. So I think that we're only at the beginning of looking at the impact of genes on long-term survival. And I'm not going to go into ST abnormality because that could be a talk all into itself. But if you look at what we do in the fetus, ST assessments are important in looking at decelerations and low heart rate variabilities, and these form the basis on which we do non-stress testing and biophysical profiles across all of the later gestations in the fetus. But right now, we have not published our work on ST segment abnormalities, and part of that is that we are still acquiring more information about the ST segment assessment, and so I think it's yet to come. So this is an interesting study that was published in 2017, and it was looking at a multi-center study of Ebstein's and tricuspid valve dysplasia in 51 fetuses. And what they found was that there was this death rate in utero of 2 of the 51 patients, but the neonatal death rate was quite high, 18 of 49, or 39%. What they showed was that the echo parameters in the second trimester did not predict the echo findings in the third trimester. And I think that is what, when I present this to you, that is what we are finding as well, that we really see this progression in severity of disease between the second and the third trimester. And so in this study, most of the patients, 65%, did have some evidence of risk factors even in the second trimester, but almost 90% did by the third trimester. So that, the risk factors are there. They do get worse with time. And in their case, they did find annular diameter was one of the risk factors, and genetic conditions another. So here's just one example. This happens to be from Dr. Howley's report, and it's not a patient with Ebstein. It's a patient with an unguarded mitral orifice. But what you see in this tracing is that we were able to show that the patient had one-to-one conduction during atrial flutter here on the right-hand side. The conduction pattern changes at the point of the arrow. And if you look down at the bottom at the heart rate trend, you can see that.
Janet, can you just make it easy and explain the diagram? Where's the ST, where's the PR, and so on?
Okay, so this is just a diagram, a continuous rhythm strip here. So this is like a 20-second rhythm strip. We mark where we show the 5-second rhythm strip here. So this is just a place where you can see the 1-to-1 conduction, and then it goes back to 2-to-1 conduction. So this is relatively well tolerated in the fetus, but this is the cause of the high drops. And it wasn't really appreciated because if you look down here at the heart rate trend graph, the heart rates are only high during a small percentage of time. This is less than 30 seconds. So that's, barely enough time to put gel on the transducer. So I think this can easily be missed by echocardiography and has important implications really in the overall, long-term effects on the fetus. So I apologize, I got out of order here. So what is the impact of the FMCG on diagnosis? We looked at 33 patients with congenital heart disease a couple of years ago, and we found altered diagnosis in 43%. Some of the things that we found in congenital heart disease, although interestingly not in Ebstein's, we did not see QT prolongation in Ebstein's, but we did see it in other types of congenital heart disease like hypoplastic left heart syndrome and heterotaxy. Bundle branch block, I'll show you more about later. Flutter with intermittent 1-to-1 conduction, VT, NWPW. So FMCG altered the clinical management in 10 of the 33 cases. So it's really interesting because if you look at FMCG and if you look at fMRI, these two technologies have a huge impact on management. But the reason they do is because we should have been using these decades ago, and we haven't because we can't get the technology pulled into the clinical arena. And recently with fMRI, I think we have seen progress in that as well. But we still need to bring forward these technologies that are used at every other time in the critical care of management of sick patients, but yet are not used in the fetus. So this is just some examples of the heart rate tracings. These are 5-second heart rate trends. So this looks just like a rhythm strip, and these are seconds along the bottom. This is just a non-sustained VT that would not have probably been evident by an echocardiogram. Here is a patient that has some ectopy and bundle branch block and some ST segment changes. And this is a patient that has WPW. The only beat that's not pre-excited is the premature beat here. So then FMCG in Ebstein's is what I really want to talk about today. And this is our experience over the last 20 years, basically, for 18 fetuses, 21 studies. And so it incorporates a large period of time. So in our experience, we had no fetal deaths, but we did have 6 neonatal deaths. These are, when I say we, these are cases managed from around the country. So we look at the postnatal record. We don't always know exactly the cause of the neonatal death. But in the follow-up, we had good follow-up in 15 patients. One just delivered last week, and I don't have follow-up. So predictors of the neonatal demise included fetal tachyarrhythmias. So in our experience, both patients that had tachyarrhythmias died. The QRS duration of greater than a z-score of +4 or 90 milliseconds, 4 of the 6 fetuses died. With progression in the QRS widening between second and third trimester, this was an important predictor and probably underlies a lot of the hemodynamic changes that occur during that time as well. And the presence of something completely unexpected is transient AV block in this population. It's really never been appreciated that you can see second-degree block in an Ebstein's malformation population. And also we saw a very significant low heart rate variability patterns in these patients, really suggesting that they may not make it to 39 weeks gestation without intervention. And other abnormal findings included ectopy. 6 of the 18 had ST depression, but none had QT prolongation. So these are just some more tracings. These are just rhythm strips. This one shows a lengthening of the PR interval followed by a dropped beat, and again lengthening followed by a dropped beat. So this is a Mobitz type 1 second degree AV block and also first degree AV block. There's in this one giant P waves. There is a prolonged PR interval. There's ST depression of the TA wave, the atrial T wave, and there's a bundle branch block. This patient was in flutter with 2-to-1 block and had a wide QRS as well. This is a patient who exhibited some sinus bradycardia and second degree AV block. You can see here that this beat drops. There's a 2-to-1 block in this period. It's hard to know if this is type 2 or type 1, but it's probably type 1. Ectopy, again, here is another dropped beat. And so these patients are at risk for second degree and first degree AV block. And I think that probably suggests that there is some conduction abnormalities when the disease gets severe, whether that's ischemia related and reversible or whether it's more, fibrosis related, I don't know. So these are the cardiac time intervals. The patients often had wide P waves. The ones in red are the babies that died, and the ones that are in red with a white circle are the ones that had flutter. So the PR interval was prolonged. The QRS was above 80 milliseconds in all but one. And what you'll notice is that over time, between the second and the third trimester, the QRS gets wider. And this is really important because the mortality usually occurs here or after birth. But but you will miss this. And in fact, at the point where you're counseling your patient, it's really not there at all. So I think it's really difficult for us to provide adequate counseling to the Ebstein's population. And it's really important that we monitor these patients over time because they will change over time. And the QTC was not long. The RR interval was long in one that died, and the amplitudes of the signals for the P and the QRS are increased. Heart rate variability in Ebstein's, normally the heart rate variability increases as later gestation goes on. This is just the standard deviation of the normal to normal beats. And so it usually is in the, 4 to 12 range, but increases with gestation. But in the patients that died, we did not see any improvement in the heart rate variability over subsequent follow-up. And so it's not always present, but I'll show you just some examples here. This is an overlying image here. These are five minute heart rate trends. So this is 5 minutes worth of heart rates, in this case around 150. You can see this is fetal activity. Normally you'd expect it to increase the heart rate, and it decreases it almost like a late deceleration. In this patient, you do see a very severe pathologic deceleration, but again, these are less than 30 seconds long, so they would be very hard to pick up by echo. This is a patient with sort of a persistent sinus bradycardia where you have a very flat, all of these are very flat. You can see the changes are in the range of 4 beats per minute over long periods of time, which is really abnormal. And then this patient was in flutter with 2-to-1, so you'd expect it to be flat in that setting with the 2-to-1 block. This last patient had some ectopy, so you can see that it's flat, but there's also some ventricular ectopy. I think that was one of the tracings. So finally, ST changes, we definitely see them. You can see here there's a splaying of the ST segment. We look at the QRS in both upward and downward positions. So sometimes you have to actually use some way of assessing the severity, but we don't know what to make of it. We've seen it in 6 of 18 patients. We don't know if it's permanent or if it's progressive. So I think there's more for us to learn in this setting. So my conclusions, hang on, I've got to get back to them, are that the fetal MCG it has the potential to help with the risk stratification, and in addition to echo, and it may help us predict prognosis, especially with the width of the QRS. There's probably a QRS width beyond which there is no survival, which would be around 100 milliseconds. Arrhythmias and mechanically silent conduction abnormalities contribute to neonatal mortality in Ebstein's and tricuspid valve dysplasia. The mortality with extreme QRS prolongation is high and likely reflects the severity of the underlying conduction disease. The transient first and second degree AV block have not been previously suspected in this condition, but they are there, and they may suggest that there's more underlying conduction system disease, and it may be impacting prognosis as well. Changes in the conduction and heart rate variability appear to progress between the second and the third trimester, and it will be important to advance less expensive forms of FMCG technology, such as OPMs, that are currently in the pipeline for approval, so that every fetal care center can have the ability to perform FMCG in the future. That's all I have. Thank you very much.
Thank you so much, Janet. This is a very high-level talk and showing the beauty of research and how we really need research in our lives. I don't have, I mean, from the group, we don't have any questions, but I have a few questions for you. Going back to the basics now, the title was The Silent Arrhythmias in Congenital Heart Disease, not just in Ebstein. And you find also certain things in Ebstein. What made you study this? Why did you think that there could be silent arrhythmias?
Well, I think we observed them. Obviously, when we started doing FMCG, we were looking only at patients with arrhythmias, and then some of them had congenital heart disease, and we recognized that some of those had bundle branch block, or had WPW, or had things that would be difficult to identify by echo. And one of the things that we've done recently is to try to combine the simultaneous echo and MCG so that we can provide the echocardiographers with ways in which they can predict certain phenomena. And so, for example, in inherited arrhythmia syndromes, we have a nomogram now where you can use your IVRT to predict your QTC. And we have an article where we looked at how do you use IVRT, isovolemic relaxation time by echo, to predict T-wave alternans. So we hope in the future to be able to come up with other means by which we can use FMCG to provide easy, reliable ways in which you can put to use some of these findings that we have that may not be as easy to, always send your patient, but I think that they could be very useful in looking at how, who do you send for evaluation if they have inherited arrhythmia syndrome, and looking at IVRT is one of the very, important aspects of that.
So the idea that you're trying, the message here is that I'm sure this is not the message. I was just saying all Epsteins should go for FMCG, or only the one with circular shunts, or which ones should we send them? Because you're trying to say we need this magnetography together with echo to plan or to know the prognosis and help us in such a bad disease. Did I get this right?
I think more than who should come for the procedure is really how can we, as a community of pediatric cardiologists and electrophysiologists, work with our funders and our programmatic approaches to do things like fund our registries, like Lindsay's registry, or fund our device development, like what we're doing to bring forward these new technologies to utilize. I mean, at every other time in the human life cycle, we use bedside monitoring and ECG routinely, but we can't use it in the fetus. And so it is possible to bring these technologies forward. And that's really my message, is we need to look at this on a broader scale of saying, what do we need and how do we get it? I think it's really sad that we can't fund registries, because that's where we learn a lot of information.
So I mean, also the importance is not just registry, but you're trying to say that the silent arrhythmias can have impact on the survival in utero. Did I get this right?
Yes, yes,
So this is very
absolutely.
important. This is
It
very
is. I mean,
important.
I think it is important. I don't think every patient can come to Madison. I think, it has to be a selective decision. We're there, but I think that, it has to be a decision that you look at with the family and decide, is it worth the risk of travel? And really the answer is for us to be able to get these devices out into every care center. There really shouldn't be that much time delay. And part of it is that OPM is relatively new. I mean, it's a quantum technology that's only been around since 2015. So it's still relatively new, but these quantum technologies are expanding very, very rapidly, as I'm sure you've heard on the news. And it really should be possible with, adequate funding of our research in the United States and elsewhere to bring some of these quantum technologies forward. In fact, I think one of the best quantum technology conferences was held in the Middle East this year. And I think that really worldwide there should be a way to do this, to bring forward new imaging using some of these new technologies. And I would include fMRI in this as well, because I think that we will never be able to adequately advance fetal care unless we're doing fetal echo, MRI, and FMCG. That's my opinion.
Also, Janet, to recap, going back to the basics, what you've seen in these studies, you've seen first degree, second degree heart block, silent arrhythmias, and a failure of heart rate variability.
Yes.
Anything else that you've seen that we've
Yes,
missed?
the very wide QRS.
Yes.
And then the also the ST segments, we're not sure what to make of
Yes.
them yet. Sometimes they're there with these other findings, sometimes they're not. So, but also the very large amplitude of the signals, the giant P waves, that's seen postnatally as well, but it does get worse in utero.
So first and second degree will not cause a lot, right? And heart rate variability, you said we don't know the value of it right now.
Well,
Is this
what we
correct?
don't know with the second degree AV block, it's really never been appreciated in Epstein's before. You know, we don't know what to make of it, but it's unusual. We don't see this in other types of congenital heart disease. We've not seen this at all. So it does, to me, it does imply that there's perhaps some degree of conduction system disease, either related to the stretch phenomenon or related to the fibrosis. And it seems to be worse in the second trimester, or I'm sorry, in the third trimester. So I think it seems to be progressive. So,
It's probably related to the etiology of whatever is going.
yeah,
So
exactly.
was that a spectrum of fetuses? And I mean, did you like say group your
Yes.
fetuses? Like I would say with a score or whatever you've done. And so this group one had this changes, group two had these changes, or
I wish it were that easy. I wish it were that easy because if you look at almost all of them look good in the second trimester. That's the problem. Then you see the third trimester, and all of a sudden there's all these new onset risk markers. And I think that that's the one thing we have to appreciate is that Epstein's is a hugely dynamic process. It's changing between the second and the third trimester. So I wish I could say that, that if they're mild, they're going to remain mild. Most of the time they do if they seem to be mild. But we just saw a patient the other day that was mild and had a QRS duration of 90 milliseconds. So, we have to kind of study more patients, I think, over time in order to know, just what the impact is of some of these things.
you talked about these scores. Where are these scores for the arrhythmias that you've mentioned? Are they hiding or they're published or where
No,
can we find them?
well, first of all, this manuscript is in its final reviews right now with the JAHA, and we hope that they'll accept it. It's not accepted yet. In that manuscript, when it finally becomes accepted by one of the journals, we have listed the references for these published articles that have our normative values. We didn't have good norms for the heart rate variability, so we just did 61 patients with heart rate variability from our normal population. We've already published our normative values on the cardiac time intervals in 250 studies in 139 patients. In the past, we've stranded all, and I could provide that if anybody needs that, but it's definitely published data, and I think that that's where we get the C scores and also Dr. Walker Guzman is getting ready to publish her data on, I think, 75 studies in optically pumped magnetometers. And we have 60 some studies, and we'll be publishing those two together probably to highlight, sort of the normative values, because most of the values to date have been done on the squid device, but the OPM is what we'll be hopefully seeing put in centers around the country. So we're, continuing to acquire normative values in those with those devices as well.
So Epstein will continue to be a mystery until we have like a home fetal ECG. Would you ask mothers to monitor the heart rates, get those devices from Amazon and try and get the heart rates? Since you're promoting that there could be serious, it's a bad disease, and I'm sure that myoendocardium is not healthy, especially in the ones, as you said, in second and third trimester. Would we advise mothers to monitor heart rates and trying to see, because we cannot do halters at home, we cannot do anything for the fetuses at home.
I
Would
think
is this
certainly for the fetus that's had a documented arrhythmia, I think it's reasonable,
No,
even
no,
with
not the
frequent EKG.
documented arrhythms. I'm talking about the secrets that you've revealed right now. Trying to have
I
all
don't think
data.
we don't have enough data to show that that would be helpful to have home monitoring in the absence of arrhythmias. The only thing it might show is the development of sinus bradycardia over time, but we only saw that in one of 18 subjects. So, until we know more, and until home monitoring gets better, I would say at this point we don't have, enough information to make that decision.
Janet, I just want to thank you so much for such a informative talk. A lot of information is very high powered, I'm sure, but I've learned a lot. I'm sure my audience also learned a lot. I'd like to thank you. This is a recorded webinar. You will find it at on the YouTube at the Fetal series and the Congenital Heart Academy. And we're looking forward for more speakers. We are having Dr. Shane Morris to join us in the next fetal webinar in August. So stay tuned. Thank you. Have a very good day and good evening and wherever you are. And thank you again. Lindsay's back. Thank you, Lindsay, from Sick Kids in Toronto. I had a great time when I was there. And Janet, thank you again. And very thank you for Sasha and from the group from the Congenital Heart Academy. And see you soon and have a very good day. Thank you. Bye-bye.
Thank you so much.